Thank you very much, Mr. Chairman. Really, it's a pleasure to be in Lebanon, and I'd like to extend my appreciation and thanks to my dear friends here, organizers of this great conference, especially Professor Musa and Fadi, Dr. Abdullah, for their excellent work they have put to introduce a program like this caliber. Now, when we talk about prenatal outcome and maternal distress or mental stress, it's something that we almost see in every chapter talking about premature labor. We just heard it this morning from Professor Langer about premature labor and stress as a causing factor. I took this situation a little bit further to look into the matter. The incidence or the prevalence of this problem has been estimated in the developing world as something like in the 15% range. Similarly in the developed world, but there they also gave us from the Canadian review that the higher incidence actually or high stress prevalence related to this problem could constitute something like 10%, where we have patients with low socioeconomic status, less than 20 years of age, single, have less than grade 1 11 education, and also have no social support. The list goes on and on, including past history of depression, domestic violence, poor social support, poor marital adjustments, experiencing threats, living in the dangerous zone, problems with the spouse, family, poor socioeconomic status and social factors, and adverse events in the previous pregnancy. So, I mean, if you question any woman, you may have something related to this, maybe in her history. However, when we talk about the perception of stress, really it's an individual thing. It is actually the stress perceived between the demand and also the adaptive capacity of that demand. So that kind of balance really resulted in a stable woman or a woman who is really suffering from the consequences of this distress. Now, there are some measures there to assess this, what we call the psychometric instruments, to assess the level of stress that this woman is going through. One of the famous ones published in 1883, which is called the Perceived Stress Scale, PSS. And it has a 10-question questionnaire and really give you an excellent indication of how this woman feels or how she's coping with the stress. These are the 10 questions, and out of the score, you may have classified her as a low-level stress, moderate stress, or a severe level of stress. Now, according to this, maybe you can have identified a certain category of patients who we need to do something about. Now, to look into this matter, okay, this is a stress that actually affects the continuation of pregnancy. In order to explain this a little bit further, understand this problem, I thought let's talk about what maintains pregnancy. The integrity of pregnancy, in my books, actually relies on 5 columns, which I call actually the pregnancy pentagon. It's starting from the ovulation, fertilization, decentralization, implantation, and of course, continuation of the pregnancy. Without any of those, pregnancy will not continue. Now, the actually hallmark behind holding all these pillars together is one thing and nothing but the progesterone, as you can see here all over these corners of this pentagon. So it's a hormone. Well, it's lucky to be, it's not just a hormone of endocrine effect, but it has another arm, which is the immunological factor. We have seen that progesterone really work on the cytokines that are related to the inflammatory origin, released from the Th1 cells, and these really actually inhibit it. And while the opposite one, which is the T helper cells 2, which are really anti-inflammatory type of cytokines, really increase, and that's why maintain the pregnancy through progesterone. Another indirect effect of chronological effect of progesterone is it's actually when it is attached to the progesterone receptors on the lymphocytes. There, where we have developed or released what we call the progesterone induced blocking factor. This does the same thing, and that's how pregnancy continues. We have found from research that if we block this progesterone attached to the lymphocyte by products like mifepristone, we block the release of the IVF. Or if we have actually agents that block the effect of the IVF, then the resultant will be a miscarriage, discontinuation of that pregnancy. In addition, we have measured the PIBF levels in the urine of these pregnant mothers in normal pregnancy and in an abnormal pregnancy that ended with miscarriage or premature labor, which have really been documented here in the blue line on this graph, where you can see the levels lower compared with the normal levels in those who continued their pregnancy. So there is some kind of a strong association with this. Then later, Professor Arab, who was in Germany that time, she did this very interesting study. Well, they enlarged at least 864 women between the age of 4 and 12 weeks of gestation without signs of threatened miscarriage, followed up to determine the cause of miscarriage later in life. So PIBF, which I just mentioned, and the corticotropin-releasing hormone, which is we all know that is released from the adrenals and the placenta pregnancy, were evaluated. Now, the perceived stress level test was actually also applied to this group of women, and we have actually developed a score. Now, the outcome of this, 809 successful pregnancies, while there was 55 miscarriages. When she took this group, actually, they found that the level of the PIBF in this group was lower and the CRH was higher, which is understandable, where this is causing maturity of the fetal HPA. Now, at the same time, the rate of miscarriage was also numerically higher amongst those with higher perceived stress scale. So we're putting this together, actually we can see easily how progesterone and CRH really working there. In addition, have identified other factors like low BMI, low PIBF, as well as the high stress levels. Now, when we talk about a fetus as a result of this unwanted behavior of the hormone or immunological factors, we can see normally there is a fetus that is better physically, but also hormonally, this fetus can be better because normally these hormones should come later at the age of gestation, where the mother talk to her baby and tell, okay, now it's time to have a baby, now it's time for contraction to start, and the CRH goes up. Well, here, a better fetus will get that messages earlier in gestation, and that's why the process starts earlier, leading into the premature delivery. So, this is the situation. In addition, of course, what we have seen that the gender-based violence can lead to better pregnancy and resulted in better fetus, which is one of the commonest really factors that have seen recently. Now, we have documentations all over the public, the literature, that maternal anxiety levels associated with adverse prenatal outcome, specifically prematurity and low birth infant weight. Now, what does this translate into? We have looked into about 80 scientific publications on stress and preterm birth, and the result major life events such as the death of a family member were at 1.4 to 1.8 times greater risk for preterm birth, with the strongest effect when the events occurred early in the pregnancy. So here we have a bad news, and here we have early gestation. Now, the most commonly studied actually preterm birth, which is below the 37 weeks, and babies below the 2.5 kilograms. Now, if we take into consideration the different type of mental stress here, we can have either an acute or a chronic one. The acute is subsidized by the pregnancy anxiety of any kind, or some kind of a catastrophic event that happened, or maybe major life events. Now, you can see that these main acute causes of stress in women lead to a preterm birth. However, if she's on the depressive type or she had some kind of chronic stress type, more likely this will lead to the low birth weight type of adverse outcome. Of course, this has its effect on the fetus, on the neonates, and even women and babies later in life. Now, I tried to comprehend this problem and put, at least enumerate the causes behind the adverse outcome as a result of maternal stress. Number one cause, of course, I have to tell you that there is no neuronal effect between the mother and the fetus. You all know this because they are separated, totally separate neurologically. However, these other factors or these other mechanisms that I'm going to introduce here, we talked about the hormone as the first one, which through stress hormones such as the release of corticotropin hormone, cortisol, adrenaline, crossing the placenta, fetal exposure to unhealthy levels of stress hormones may impact the baby's brain development and cause abnormalities in the fetal axis. We can see here again the corticotropin hormone usually is released from the placenta and the maternal adrenals, which give the signal to the fetus where we have the established labor at the term pregnancy. However, stress hormones start to release these adrenalines and also these CRHs from her brain at the time during the stress levels throughout the pregnancy. That's why it will accelerate the stimulation of this fetal axis. The other mechanism can be nutritional. You can see here that chronically or severely distressed mother may feel overwhelmed and fatigued, and which is really sick, and as a result of her distress, impact their diet and sleep habits, and also may compromise the fetal development. The third mechanism that can be really considered here, which is really something very objective, and maybe some research is going on now on this problem, which is the chronic or extreme maternal stress may also cause changes in the uterine blood flow and to the fetus, and which leads also to the fetal growth restriction. These are animal studies that has been done where we looked at the significant discordant relationship between the woman with the high anxiety and the presence of waveform changes. We all know that the presence of a notch in the uterine arteries denotes some kind of high resistance to blood flow. This is something has been seen in animals actually exposed to stress, and the notch was present. So something maybe need to be looked into it and practice in women or in human publications. The fourth possibility, as we all know, always the epigenic story comes in the picture. We have identified actually a gene, the glucocorticoid receptor gene, actually has been leading to impaired glucose metabolism, leading to, again, the low birth weight, and finally the immunological part, which is the Th2 immune responses, which is interleukin 6, which has been associated with the premature labor. Now, apart from this theory and the possible mechanism, what about the psychological status here? What are the outcomes of these problems? When we talk about mental diseases, this is the incidence, the prevalence of different type of psychological disorder. We can see here the general anxiety disorder, something like 8.5%. The post-traumatic stress disorders between 3 and 12% rate, panic disorders 1 to 2%, obsessive compulsive disorders 0.2 to 1%, depression up to 18%. So really this is a major health problem that affect women with a high prevalence rate occurring during the pregnancy. Now, if talking about depression, for example, depression and anxiety during pregnancy have been associated with adverse pregnancy outcomes. They are less likely to receive adequate perinatal care, poor nutrition, more likely to use alcohol, tobacco, and others, preterm delivery, increased risk of having preeclampsia, operative delivery, bleeding during pregnancy or miscarriages. The psychologists, they're always, and psychiatrists reminding us of these problems. Be careful of those patients who are depressed. Not only that, but also one study found the relationship between depression and the pregnancy outcome for teenagers was not really a problem, but for adults it was as a major risk factor that has to be because the conception or maybe the life problems increases around her in later adult life. Bipolar disorders, for example, has been associated with abnormal CTG just during intrapartum monitoring, as well as placental abnormalities related to her condition. Now, this is a bad one. Schizophrenia. Maybe you came across 1 or 2 patients in your practice. Here we have a prevalence in pregnancy unknown, but they are actually reported to have the worst pregnancy outcomes. They have, in fact, fewer total lifetime pregnancy. They don't really actually manage to get pregnant sometimes, and lower rate of live births, less medical care, 2/3 got lost, and also high rate of losing the pregnancy associated with hypertension, substance abuse, preterm delivery, small gestational age, stillbirth, placental abnormalities, and even cardiac defects. Now, it seems to be that stress or maternal stress and anxiety in pregnancy is one of the things that is touchable and which is something more common when you have a patient who has shorter gestation age as a result of this. However, we need to know actually what to do about this woman. That's really what triggered me to do some study that is still in preparation, and I was going to share with you some of the preliminary results. Here, we're necessary to do something with the post-traumatic stress disorder, because here we can identify a stress that I can work on, and then of course I can use the scale. So what I have here, actually, we have a group of patients who got pregnant within a month of an identified traumatic stress. So at least this is identified, and within the first month of she got pregnant. Majority of these patients actually had a parity of 1 to 4, aged between 20 and 30, middle class, good income, and completed the higher education. So there is no other maybe stressing factors, but from that particular post-traumatic incidents that she came across. And the control group, of course, they had none of this, similar distribution, but they didn't have that distress. Both of them, they were asked to do the PSS. Now, the moderate and severe stress level, according to the scaling that we have used, actually was significantly associated, had higher incidence of adverse pregnancy outcome. I have seen that the miscarriages rate, odd ratio of 2.1 in this group. Hyperemesis gravidarum is 5 times. And also the preterm is something double or twice. So this is really preliminary data. We are just going to finalize the whole calculations and statistics to get it ready for publication. What to do? The treatment is usually untreated mental illnesses can be dangerous to both the mother and the fetus. Now we have the mother with poor nutrition, drinking, smoking, and other behaviors, and a fetus that is going and may have resulted in premature birth, low birth weight, and also maybe having late development problems later on. But the problem with the treatment here is something that we all face. Now, number one is the psychotherapy. The stigma. When you tell a patient go to a shrink, she should stop. She doesn't go. But when you have to persuade her. Now, access to care also, insurance issues and financial issues, resources can be a problem. Environmental barriers. Psychopharmacology, this is really our problem. So we have to be very careful about giving advices. Whenever we hear a woman, she's on antipsychotic drug, oh, this might cause a genetic teratology or some kind of not in the fetus. So this kind of fear of medication may result in suboptimal treatment of these patients, and also the risk and benefit is not really weighed carefully. So these are the list of major problems that may encounter the fetus, like shorter gestation, low birth weight, smaller for weight, and also risk of miscarriage. For the infant, it may have also later in life developmental problems, increased fussiness, problems with attention, recreation, emotional activity, and even lower score of major mental development. Later in childhood, hyperactivity and also emotional problems have been seen in more girls than boys. Now, so the take-home message out of this, ladies and gentlemen, really is that please do not underestimate the maternal psychological stress. Perceived maternal stress scale should be an integral part of our antenatal assessment. And to close, I'd like to share with you these spiritual thoughts. In fact, whenever we talk about stress, it's nothing more stressful than the day of judgment. And God in the Quran, He mentioned this ayah, يا أيها الناس اتقوا ربكم إن زلزلة الساعة شيء عظيم يوم ترونها تذهل كل مرضعة عما أرضعت وتضع كل ذات حمل حملها. In English, O mankind, fear your Lord. The convulsion of the hour, the judgment will be a thing terrible. The day you shall see it. Every mother giving suckle shall forget about her suckling baby, and every pregnant female shall drop her pilgrimage, which is Surah Al-Hajj, ayat 20. Interestingly, I was looking into the Bible, and I found a similar explanation about the stress effect with using the same notions here. In the Bible, with Luke 21:23, it says, but woe to those who are pregnant and to those who are nursing babies in those days, for there will be great distress in the land of wrath upon these people. God already told us about stress, and the example used is the stress on maternal, and it's as a maternal adverse outcome. So, not to forget about this. Thank you very much.